So welcome, and this was a very last minute thing. As you're probably aware, I only sent out the message this morning, but I just thought it would be very useful to have a forum where we could have some Q&A, especially for those who are going to be sitting the exam very imminently this week. But this is going to be very useful for those of you who are resitting next year or sitting for the first time. So I'm going to start off with just a few slides, and then we're going to really throw it out. And I'd ask you to use the chat group if that's okay for any questions. And I'll ensure that all your questions are answered tonight. It's going to last about 45 minutes. For those of you who haven't been taught by me or not attended a Mentor SCA webinar, I'm seeing a lot of familiar faces in the waiting room, so that's really nice. My name's Nigel, and I'm the lead GP training program director for St Mary's Scheme. So I've been a TPD for about 17 years and been involved in MRCGP training for well over 20. What we're going to be doing tonight is I'm just going to revisit very quickly. We're going to split it into like three 15-minute portions. 15 minutes just to revisit some of the top tips to ensure that you don't fall down specifically in terms of the data gathering, the clinical management relating to others aspects. But then some Q&A, and I'm going to throw it out to you guys to ask the questions about how to kind of maximize marks. If you've got any questions at all in any of those domains and what those domains mean to you, then very happy to demystify some of the quite mixed messages out there, really. And there are a lot of mixed messages. So some of the stuff that I'm going to say will go against the grain. It might be a bit contentious. This is obviously just my own opinion of having taught for this exam for over 20 years. And then the last 15 minutes specifically talking around the SCA blueprint and around, I suppose, specific cases. Now, obviously, we're not allowed to talk about the details of cases that have come up in the RCGP SCA exams, but we can certainly talk about strategy and themes. So very happy to give you my advice on how to approach certain types of cases. And then we'll finish with a few special offers. So the results have come out now over the last academic year for the SCA, and they don't read particularly well. That there has been a report that's come out more recently around differential attainment, but unfortunately, a quarter of people have not declared their ethnicity, which is a really high number actually, compared to the days of the RCA and the CSA, where only about 2% of people wouldn't declare their ethnicity. So it's impossible to understand what the differential attainment rate is, but the overall pass rate, unfortunately, as you can see, is much lower compared to both exams. And I suppose tonight, we can certainly talk about why that might be and how to make sure that if you have already fallen into that hole, that we give you the strategy to pull yourself out of that hole. And strategy is really all about having a battle plan. If you haven't watched some of the case interviews with some of our successful ST3s, and there are a number that we've put out there now, I would really encourage you to do so because they're short, they're sharp, they're very specific. I can't sit through more than a sort of 20-minute interview when I'm watching anything. So, all of these are about either 10 minutes or less, or about sort of 15 minutes or so. But Attar, who was a top scorer, if you've not seen that interview, then please watch it. Irbaz, who really went from sort of zero to hero. He first failed the SCA and then really maxed out being a top scorer. That interview's just gone onto YouTube. Really fun interview to do, and lots of insight as to how to maximize your marks in all of those three domains. And of course, demographics matter. If you're an IMG, I appreciate you might be pensive, you might be worried about this exam, but it is completely attainable. Faisal smashed the SCA, right? Really having a really fantastic game plan. But if you are someone who's failed this exam before, don't lose hope. It's really important. But something different needs to change in the sitting that you're going into, and that is absolutely imperative. If you go in with the same technique, I am very sorry to say you're just going to come out with the same result. So something definitive has to change. And hopefully tonight we can start dissecting that apart for you. So just as a reiteration, tonight the Q&A is going to be based around data gathering, clinical management relating to others. Remember, the clinical management name carries 1.5 times more marks compared to the other two. And obviously on the day, you're going to get a global overall rating and then the pass mark determined by the borderline group method. So it depends on how strong your cohort is. And ultimately the pass mark will range between sort of 72 to 76. We can certainly talk about this in more detail. I have got this on my website in terms of the Mentor SCA mark sheet. It is so important to be aware of the competencies that you're being marked on. And if you have a look at this, I think the thing that I really want to draw to your attention is that all of these competencies are summative and they're negative. That is to say, every time you demonstrate a behavior out of context, you are not getting marks, you are losing them. So the best way to see this exam is an exam that is negatively marked. Every time you demonstrate a consultation behavior which is completely out of context, for example, oh, I'm just wondering, do you smoke? Do you drink alcohol? You get no marks for that. I mean, have a look at the mark sheet yourself. Is there any marks for asking about smoking and alcohol? Yeah, absolutely not. So, these questions have to be in context to the narrative. If you ask them out of context, you lose marks basically. So we'll talk about obviously about these aspects in a bit more detail in our Q&A, but the ones in red are the ones that are highlighted because as a chair for ARCP, when I'm seeing SCA failures, these are definitely the competencies that people are failing on a lot of the time. We'll cover this in the top tips in a second. So this isn't a tick box exercise. You're being assessed on behaviors, and it's about being real. In real life, you'd have a conversation that's really difficult under simulation. I get that. You're nervous, you're trying to solve a problem, but what tends to happen is you then process, you don't acknowledge, you end up talking at the patient, not with the patient, and then the active listening is completely compromised. So it doesn't feel real. And we all have processing words, don't we? We all have filler words. Okay, fine, right. I'm so worried about this headache, doctor. Okay, fine. No, it's not okay. It's not fine, is it? And it's not just about what you say, it's how you say it. I'm sorry. Are you? Really? You don't sound particularly sorry, as opposed to, I'm sorry. I've said the same words, haven't said the same thing at all. So the nuances of communication are absolutely key. If you're going in thinking this is a clinical skills assessment, then it's not. Okay, because ultimately it's a communication skills assessment. Yes, clinical skills are important when it comes to managing risk and uncertainty, but this is not testing your diagnostic ability. So if you are just simply chasing a symptom and a diagnosis, I'm afraid you're going to find a dead end pretty quickly in this exam. So this isn't a typical clinic, no matter what anyone has said out there, and there are so many mixed messages of people saying, oh yeah, just see loads of patients, it's be fine. Really? Well, patients aren't standardized. Patients don't have a script to follow, and actually patients don't necessarily fit an SCA blueprint. But there are definitely aspects of patients that we can use in real life to help you with behavioral indicators, negotiation skills in particular. You all have patients that make you feel, ugh, that kind of heart sink moment. Use that opportunity to make sure that you don't feel like a heart sink doctor. How do you counter energy with energy? That's going to be really, really important. This aspect of transference. It's not a cot. Time management is key. It's summative. We always operate a 7 to 5 minute split on the masterclass. Again, you're going to hear lots of mixed messages. Oh, it's 60. It's sort of 6 minutes and then 6 minutes. I don't think so. At the end of the day, you're going to spend a lot of time in data gathering, but you can optimize the time that you do spend in that domain by using the notes in context, case priming, and having a battle plan. You can absolutely do the clinical management in 5 minutes. You can even do it in 4, but anything less than that, it's going to be a real push. So it is a game of two halves, and it's really important to know your place in that patient's narrative. When you get into the car journey with the patient, recognize that journey in terms of case priming has already started in the patient's notes. What has happened to them, which you need to utilize to prioritize the way in which you gather data? If you are not using that information in context, you are going to be chasing your tail. You can't sit behind an examination or investigation before making a commitment to a management plan. So if you're someone who's risk averse, if you're just going to be bringing patients in, that means there's something fundamentally missing in your history, unfortunately, which means you cannot commit to risk. There is no SCA case that's been written up which requires you to physically examine a patient before you make a commitment to risk. Okay. Of course, you can bring patients in for examination, but it should not deter you from making a commitment to a clinical management plan. And a clinical management plan, by the way, is not just about doing investigations and waiting for the results. That's sitting on the fence. So when it comes to, for example, follow-ups, deliver the results. In real life, you would do, why aren't you doing it in the SCA? First big mixed message, I need to retake a history. No, you don't. You wouldn't do that in real life. Okay, in real life, you'd want to know what led to the result. You would want to know what was discussed in the previous conversation, and then you would give the result. In Breaking Bad News, guess what? You can't be assessed on Breaking Bad News until you've broken it. So why would you hold on to a result for 6 or 7 minutes? It doesn't make any sense, and that's a really, really big mixed message. On the masterclass, we teach you to deliver the result quickly, but knowing your place in that journey within the second to third minute. So it's very much about transference. The reason why people find this exam so difficult is because it is about communication, and communication remotely, just as I'm talking to, a blank audience. I know you're not blank, of course, but I kind of shut your videos down. Is not easy. You know, it's about how you engage and how you showcase that you are the drug in that consultation, how you acknowledge, empathize, energize. So we teach this acronym on the masterclass, AEE. AEE is your friend. Every time that anything's emotive, don't process that emotion, acknowledge it, say what you see, mean what you say, empathize with the situation, and think about what you can do to actually help. Don't just process what's happening in front of you. All right. Top tip one, make sure you use the information provided in the case notes. Okay, so I was doing one-to-ones all day today, and I made a candidate do a case 3 times in a row over an hour because it just wasn't good enough, basically, because they just were chasing that symptom. They weren't understanding where they were with the narrative, what's already been done before, asking questions to which they should already know the answers. So make sure you know your place, and definitely in a follow-up, make sure you get those results out early, okay? Never park a queue. It's a standardized exam, all right? Patients in the SCA have a script which they have to adhere to, strictly adhere to. They're allowed to give you 2 lifelines in terms of queues. If you have not picked up the queue on the second occasion, it will go. Never say, I'll talk about that later. Talk about it now, okay? Because it will take you to the heart of the narrative, and this is a narrative-driven exam. Make sure that you open up a patient's ice early. Again, in a standardized exam, every role player is going to have some component of ice in their narrative. The opening statement might be, I want an MRI scan. Great, I've got the expectation. There's no need to over ice the E, but what is the I and the C that comes before the E? You have to be curious, okay? No generic or formulaic questions. If you're someone in your study groups right now who is literally saying, just to get to know you, can I ask, what do you do for work? Who lives with you at home? Do you smoke? Do you drink? You can absolutely forget that. Okay, that is a mixed and terrible message. There are no marks for taking a psychosocial history. It is a psychosocial perspective that we're interested in. And a psychosocial perspective is putting yourself in the patient's shoes and understanding the situation around them. So it's really, really important that if you are going to ask questions which might appear out of context, you signpost them. Signposting isn't saying just to get to know you, can I ask some routine formulaic questions? Signposting is, given that you've had some changes in your bowel habit and you've got abdominal pain, lifestyle habits might be really important. I can see from the notes that you don't smoke. Do you drink any alcohol? What's your caffeine intake like? And how is this abdominal pain actually interfering with your daily activities? Is it interfering with work? That is a psychosocial perspective. Signposting is also really important when it comes to sexual health. Are you someone who says this in sexual health, by the way? Can I just ask you some personal questions? That's not a signpost. Personal questions could be recreational drug use, could be anything, couldn't it? Could be like what color I like. That's not a signpost. A signpost is, given the nature of your symptoms, we have to keep an open mind, because sometimes these symptoms can be related to sexual health. Would it be okay if I asked a few questions around your sexual health? That is a signpost because it shows direction of travel. So it's really important that you are absolutely key in how you're asking questions. You are being assessed on how you manage risk. This does not equate to being risk averse. This does not mean over referral, over investigation. There are 3 levels of risk in the SCA, indeed in real life. Your history alone should allow you to determine, is this serious enough to warrant escalation? Underpinning that, there are 2 levels of risk escalation. Serious enough to warrant admission, perhaps today. Urgent unscheduled care, serious enough to warrant urgent investigations, maybe a 2-week wait. Or if it's not serious, your job is to risk contain this without over-referring and without over-investigating. So again, really, really important that you understand that all of these cases are built such that from your history alone, you should be able to commit to risk. We are not looking for people who are risk averse. And if you are committing to risk. You may not know what exactly is going on, but you may know it's potentially serious. Consider how you're going to present that to your patient because they may not be expecting that. Cancer, by the way, is a scary word, and that action will definitely have a reaction. The word cancer has to be out there, but how you swim towards that and how you present it is absolutely key. So you're going to be dealt with, patients who are emotive, patients who are not expecting what you are about to tell them. How do you handle that situation? And that is through AEE. Acknowledge rather than process. If you are someone who's saying, okay, fine, right, sure. So again, I was doing some one-to-ones today. I always count the number of okays, fines, and rights set out of context. The record number on my course on the masterclass is 72. 72 okay, fines, and rights set out of context. I'm so worried about this. Okay, fine. Okay. It's really affecting me. Sure, fine, fine. To the point where actually on one of our masterclasses, our simulator said, if you say okay or fine one more time, I'm going to end this consultation because there is nothing today that I have said which is okay or fine. So acknowledge, say what you see, mean what you say. I'm so concerned about this. I hear you. I see you. Be curious about that concern. Empathize with the situation and then think about what you can do in terms of energy to help. You can only truly empathize if you firstly acknowledge, which is why we've created AEE. And if you get caught up in that countertransference, remember, counter nervous energy with positive energy. Because if you're nervous, then everybody else around you is going to get very, very twitchy, including the examiner. It isn't about just being nice. It's about being nice, firm, and fair. If you cannot meet a patient's agenda, which you will find a lot in the SCA, then it's going to become a negotiation pretty quickly, which basically means you recognize the dilemma of what's being asked of you earlier rather than later. And you use that word, and you'll see why, because it's in the blueprint. Is it a dilemma of risk versus benefit? Is it a dilemma you can depersonalize because you can't do it anyway? Maybe it's a controlled drug. Maybe it's governed by budgetary governance. Maybe it's governed by law. But if you say no, think about how you present that and always think about what you can do to find the compromise and find the middle ground. But if you are just patient driven, if the patient comes in and goes, I want this sick note, I want this referral, I want this upperclone, if all you do is just give the patient what they want and they leave happy, that's a very bad sign in the SCA. That basically means you've completely bombed the case. Okay. So your patient may not leave happy in the SCA. That's probably a good sign, to be honest, in a negotiation. But you should have found the compromise. And this also means, are you doing this correctly in your study groups? In the masterclass, our active participants set up virtual SCA study groups, which work very well because everyone's calibrated at a very high level and no one is fearful of giving feedback that actually matters. So if you're just going through right now a casebook, going through the motions of ticking those boxes in those casebooks, it's not going to happen for you guys. I'm sorry. You've got to call out bad behaviors, which means you need to know what these bad behaviors are. You've got to call them out. You've got to be critical and constructive and supportive, but you've got to be critical first, which means don't collude. Okay. Right. So now we throw it to Q&A. We're going to use the chat group for any Q&A at all. This is the blueprint, obviously. We are going to ask you firstly to think about your data gathering and specifically if you've got any questions around that and specifically how to kind of maximize data gathering. So use the chat group, please. I'll give you a minute or so. And we've got about 5 minutes on this section if you want me to answer any question. And it can be any question. There's no silly questions here because if you've got a question that needs to be answered or demystified, now is the time to do it. So I'm going to give it another minute. If not, then we'll move on to the clinical management in a second. How to maximize data gathering? That's a good question. So maximizing data gathering is about prioritization of data. So if a patient, for example, has come in with a headache and you can see in the past that they've had headaches, okay, you want to be using that information early on. So I can see in the past you've had a migraine, you had this treatment. Is this headache similar to that? It isn't? Okay. So had you any thoughts as to what it might be? If they've had no headaches in the past, then also use that. I can see you've never had any sort of headaches that you've seen us before. Had you any thoughts as to what was going on? So use it to try and open up ICE. Okay, really, really important. Richie asks, should you open up ICE before detailing symptoms, red flags, and psychosocial impact? Yes, I think you should, Rishi, and I'll explain why. If a patient comes to see you in real life, why are they coming to see you? Okay, they're coming to see you because they've got concerns. So surely it's in your interest in real life anyway to open up a patient's concern. The reason you should open it up earlier in a standardized exam is because I can use it. Of course, if that patient comes in with a headache, I want to know if they're worried about something. If they're worried about a brain tumor, I can use that to focus down on their agenda and use it to focus down on neurological red flags. Now, the caveat to that is if the opening statement is, I'm worried about this headache because it's affecting my work, then you follow the cue and you open up the psychosocial perspective at that point. Okay, but you will have been taught out there, and I know the mixed messages already that people are getting, again, contentious message, but it's true, of saying, okay, well, can I just ask a little bit about you? Let's get to find out about you first. No, forget about that. It doesn't work that way. If a patient directly asks about how to manage a condition early on, should you go straight to management straight away, or is it best to gather more data before sharing the management? Very good question, Weiss. So a patient comes in and they specifically say, I've got insomnia and I specifically want to have diazepam. Do we then start managing the situation at that point? No. What we do is we specifically say, okay, so I can hear that you want diazepam. I can see from the notes you've never been on that before. Although diazepam is an option, the dilemma, because it's a negotiation of the patient's opening statement is, I want this, of diazepam is this. So we need to keep an open mind. So you always acknowledge the dilemma early on. You acknowledge the elephant early on. Now, your question was specifically, if I ask how to manage a condition, then I need to be acknowledging that and saying again, there are many ways in which we can manage the condition. There are medications, there are lifestyle habits that we might be talking about. But before we go down that route, can I just ask a few more questions to see, how we best move forwards with you? So you must always, always acknowledge. You don't have to manage, but you must acknowledge, okay? How do we go from a pass to clear pass in domains? This is a very interesting question. The relating to others domain, okay, is also quite intertwined with data gathering and clinical management. The relating to others domain is the most labile mark, okay? It will fluctuate throughout the whole 12 minutes. So to maximize your data gathering, you really need to firstly prioritize how you prime the case, but it is interlinked with relating to others in how you follow up on cues. Okay. If a cue has to be given to you twice, you're already compromising not just your relating to others domain, you're compromising your data gathering domain also. So both data gathering and clinical management are intertwined with relating to others. What we see really is that people who do very, very well in all three domains will generally have a very high mark in relating to others also. Because they're not just being nice, they're really following through and they're managing the patient and their situation as just opposed to the symptom. I love these questions. Can we move on to clinical management now? Okay, so any questions around clinical management, please? Type them in. I might start the conversation off, which is often I ask, do I need to know a diagnosis to pass a case? No, because you're being managed on how you manage uncertainty. And there are definitely cases in the SCA where there's no clear diagnosis whatsoever. What we're interested in is how you manage risk, and that should be based on your history. So if you feel that, someone with a visual disturbance is serious enough to warrant escalation to an eye casualty, independent of the cause, then escalate them. The dilemma is they won't want to go. So how do you negotiate that? If I've got acute eye loss because of glaucoma or retinal detachment, it doesn't matter. I've still got to go to the same place. How is it best to manage if we're running out of time? Well, I think the issue really is making sure that you're always moving forwards. So often what tends to happen is you'll be in the clinical management section and go, oh, dope, I forgot to ask that question. Firstly, ask yourself, is that really going to change what I do? Is that particular question of smoking or that one red flag that I forgot to ask going to change it? And if it doesn't, you must move forwards. Remember, the clinical management section carries 1.5 times more marks than any other section. So once you're in there, you've got to keep moving forwards. And the other thing about time management is please don't over summarize. Over summaries are a huge waste of time. They show nervous anxiety, they showcase poor time management, and specifically, they showcase everything that you have missed rather than everything that you've listened to. Uzma asks, is there a mark for stating diagnosis? Well, look, if it looks like a duck and it quacks like a duck, then it's a duck, and you should stipulate it. Okay, it's okay to also stipulate what you think the differential might be. But ultimately, what you're being managed on is not how you manage the diagnosis, but the patient with the diagnosis and their situation. If there's something you don't know in terms of management, do you lose marks by saying, I'll double check and look and get back to you? It depends on the situation, Sarabika. I mean, it is a good question. So, for example, a patient, might say to you, are bedwetting alarms available on the NHS? It's absolutely fine to say, I'm not sure. I'll have to double check and we will definitely get back to you on that respect. But if a patient kind of asks you, well, what's going to happen now? Is this serious or not serious? And you kind of go, well, I don't know. I'll have to check with a specialist and get back to you. Then that's not okay. You have to be able to commit to risk. So your question was specifically around, I suppose, administration aspects, documentation for travel insurance. It's okay to say I'll check and get back. That's okay. But ultimately, we have to see a commitment. You're not going to have more than one differential, Weiss. If you're already thinking I'm having several differentials, you've absolutely missed the nub of the case. This is not an OSCE. This is not an examiner saying to you, what are your top 3 differentials? Okay. Either there is no differential at all and it's really unclear and you're managing risk, or there is a top differential. For urgent unscheduled care, if they need to go through to A&E, should you talk through what they may do in terms of investigations? Weiss, let me tell you something. No one will want to go to A&E in the SCA. So you can even forget about having that conversation. Your job is just to get them through the door. Don't even worry about thinking about the investigations that are going to happen in A&E. That is not what this exam's testing you on at all. If I said to you, Weiss, right now, are you happy to go to A&E? What are you going to say to me? No. Why? I don't want to wait 12 hours in the A&E corridor. I don't even care what investigations are going to do. You've missed the point there, Weiss. It's a negotiation. Any urgent unscheduled care and risk escalation, your patient, they want women to be risk escalated. Let's move on to relating to others. Any questions there? I'll start the conversation off then. Is relating to others just about being nice? No. What's being patient-centered? Is it about sharing options and allowing the patient to choose? No. Because those options might be inappropriate. And actually, the patient still may drive the consultation. Remember, it's a journey, isn't it? You're getting into the driver's seat. Who's driving you? But your patient is always next to you. What's being patient-centered? Being patient-centered is about being invested in ICE. ICE so you can use ICE, so you can readdress it, but also recognizing in the SCA, a lot of times you're not going to meet a patient's ICE. You will not meet their expectations. Being patient-centered in the exam equates to negotiation. And as soon as you have negotiation, it goes back to this word here, dilemma. This word, this examiner buzzword that existed in my era, when I did this exam 23 years ago in the Vivas, was in the CSA blueprint, RCA blueprint. It's now in your blueprint. So when you have a dilemma, verbalize it early on. Could be controlled drugs, risk versus benefit. Could be because of budgetary governance. You can't do it anyway. Can't do it under the NHS. Could be fitness to practice, GMC, DVLA. If it's a hostile patient, How do you show that you're relating to others? By recognizing their anger, acknowledging their anger, being curious about their anger. I think your colleague is rubbish. I can see that you're very upset. I'm sorry to hear that you didn't have a good experience. Tell me exactly what happened. I'm here to help. It's about AEE. Acknowledge, empathize, energize. Your colleague is so crap. Okay, fine. No, it's not okay, is it? It's not fine. He's rubbish. If you can't acknowledge an emotion, you won't be able to empathize with one. It's all about transference. Angry patients are easy. Easy. Anger is an easy emotion to handle. You want an emotion that's difficult to handle? You get a patient who's over-friendly, manipulative. Don't even worry about hostile patients. Hostile patients, they're easy. Patients who want to be your friends, completely different matter. What are some suggestions practicing relating to others in day-to-day practice? Excellent question, Carol. Negotiate, negotiate, negotiate. Start easy. Antibiotic negotiations, move it up. Sick note requests that are not appropriate, move it up. Referral requests that are not appropriate, move it up. Controlled drugs that are not appropriate. Sleeping medications, all of this. These are your SCA patients. Fantastic. You've got so much fruit out there to pick and practice with the right patient. How not to sound formulaic? Yeah, good question. I'm going to ice you now. What are your ideas, concerns, and expectations? You're going to ice me? The cue is king, queen of the consultation. So you always follow the cue to ice. I'm worried about this headache. You mirror. No, I can see that you're worried. Did you have a particular concern or thought as to what might be causing this headache? I'm just worried. This might be a brain tumor. No, I can hear that. And can I ask, where did that stem from? It's always about curiosity. My friend, he was having migraines, or what was thought to be migraines last year, and then brain tumor, missed, dead in 2 months. I'm very sorry to hear about your friend. And I can see, obviously, why you've got that concern. When you made the appointment today, had you any thoughts as to how you like to take things forward, as opposed to what were you hoping I could do for you today? So again, think about your language, think about your pacing, think about your tone. With a 2-week wait patient that you really want to go on that 2-week wait appointment, they have other priorities. Where do you draw the line? I love that question. That's a great question. You can't force anybody to do anything that you don't want them to do. So in a negotiation such as that, you'd be saying, look, I can understand you want to go on this holiday, and I appreciate it's really important for you. I suppose the dilemma, because it's a negotiation, is that this is something that we would want to look into earlier rather than later. And if we can look into it earlier, we can actually then think about how we take things forward. Because potentially, if this is something serious, I'm not saying it is, but if it is something serious, the earlier we diagnose it, the more we can do to help you. Now, ultimately, I understand this is your priority, but may I suggest that, we wait for that appointment. And if it does interfere with your holidays, then obviously we can make a choice at that point in time. But I'd encourage you to think about perhaps seeing this through, if that's okay. Not just what you say, how you say it. Being patient-centric isn't saying, I think you really need to do this appointment. It's really concerning. You can't scare anybody into doing anything, okay? It's a negotiation. And the word dilemma is what you needed to have there, Subrika, in that comment. Any other questions about relating to others? All right, final part then. We talk about some SCA cases. Some of you guys have put some of these up already. I'm happy to talk in the remaining 10 minutes about any specific sorts of cases that you want. This is a good one. So if the patient doesn't have capacity and doesn't want admission, what do we propose next? This is a very good question. And this actually has come up as a theme in some SCA cases. So it resides really, obviously, on the GMC, doesn't it? If a patient doesn't have capacity, firstly, do they have a lasting power of attorney? So do your data gathering. Do they have a next of kin who can advocate for them? Yeah. So it isn't, don't just assume that this patient, because they don't have capacity, doesn't have someone to advocate on their behalf. So that's very important in terms of your data gathering. But if they don't, then obviously the dilemma at this point is if we, and also do they have any sort of advanced directive or advanced refusal of treatment? But if they don't have any of those things, then the issue really is an ethical one, isn't it? Which is um, do no harm versus best interest of the patient. And if a patient does not have the capacity to make an informed choice, then we as doctors have to act in their best interest, whatever we deem that to be. So it's really important that that discussion is had with either a third party or whoever you're consulting with. So it's a really good question. But again, it's a discussion that needs to be had. It's a negotiation. Any other questions at all? Okay. All right. Well, something different tonight, obviously, and I hope you found that useful in terms of discussion. I certainly did. And if you want to join us on our masterclass, we are here. We've been running now for a long time. We've seen through a lot of people through this exam very, very successfully, and a number of top scorers. But most importantly, I think the power of the masterclass are the virtual SCA study groups that are set up, because you're studying with people who are calibrated to the right level, not just colluding in study groups where the blind are following the blind. Very, very dangerous to be there. You've got to have some tough love, guys. I'll put this up here. I hope you don't mind just disseminating that if AKT is bothering you or your friends. We maximize strategy, and we're doing a special offer as well. So the masterclass dates are getting booked out pretty quickly at the moment. 10 to 12 weeks in advance of your sitting is what's ideal. You can come as an observer if you want, but I would always say active is better. So you can set up the virtual study groups. One-to-one mentoring, so busy right now, only offered for those who've attended the masterclass, I'm afraid to say. But the special offer tonight is if you want to access the Mentor online consults. So this is me demonstrating my technique over high challenge cases, showcasing all these top tips that we've talked about to showcase the top marks. And these are not easy cases, lots of dilemmas afoot. Then we're offering £50 for 30 days access. This offer will be valid for 24 hours. If you wish to book it, then I'm just going to paste, oops, no, not that. I'm just going to paste the booking form in the chat group. Just give me a second, because if you want to take advantage of it, it has to be a bank transfer, okay? Because otherwise, the website, you'll have to pay the full price. So that's the booking form. Otherwise, you can email me at mrcgpcourses@yahoo.com. That's my email there. And once it's paid up for, the code will be activated for you and sent to you within 24 hours. When do I have January, February practice sessions dates up? So I usually release my dates about 6 weeks in advance. So more December dates will be coming out soon, and then we'll move to January and February. But dates run every month. Do check the website. And thank you so much for coming tonight. I've really enjoyed this impromptu meeting, and very nice to see some of you again. And thank you for your very, very interesting questions. I think it struck a lot of debate, which was good. Hopefully, I'm going to get this up onto YouTube a little bit later this weekend. Okay, guys, enjoy the rest of your lovely Saturday evening. Thank you so much for joining me. I know it was very last minute, so I really appreciate you guys keeping me company, albeit virtually. All right, take care, guys. I'll see you later. Bye now.